and welcome to the first session of MedCity Invest Digital Health Conference. My name is Orundhati Parmar, and I'm the editor-in-chief of MedCity News. Crisis and opportunity are two sides of the same coin, and I feel that that's an apt analogy for what digital health companies experienced during COVID. Tech was deployed at breakneck speed, and care delivery was transformed almost overnight. Now, 18 months later, we're in the throes of the Delta variant and far from declaring victory over a vanquished virus. However, there is enough information out there to begin examining where technology can be deployed most fruitfully. We must be aware that in our excitement to deploy all these powerful technologies, that we don't forget that there are real dangers out there. For example, algorithms and machine learning that we keep hearing so much about have the real potential of being infected by human bias. So all of these things are going to be discussed during this week, including topics like digital health investment trends, reimbursement, and emergence of new technologies like digital twins in the life sciences. However, I felt like it's very appropriate to begin where all of us are at today, in the home. So how has home health evolved during a time of peril for so many? To discuss that, we have assembled a very knowledgeable panel, and I will begin introducing them. So we have Anish Krishna from McKinsey & Company, Rami Karjian from Medically Home Group, Sarah Linares from Change Healthcare, and Eddie Paloki from WorkPath. This session is also being sponsored by WorkPath, so thank you very much for that, Eddie. So Anish is a partner at McKinsey and focuses on M&A, transformations, and growth strategy primarily in health insurance segment. He has served leading national and regional health plans and systems, integrated delivery networks, regional payers, and providers. He co-leads the transformations and post-acute care work for the healthcare systems and services practice in North America. Anish has also been leading the firm's thinking on the impact of a downturn on healthcare organizations and strategies to build resilience in a downturn for healthcare organizations. Anish joined McKinsey as an associate partner in 2014. Prior to working at McKinsey, he was a principal at a global consulting firm where he served several hospitals and health systems on both operational and strategic issues. Welcome to you, Anish. Rami Karjian is the CEO and co-founder of Medically Home Group. Since 2015, Rami's efforts have been focused on scaling Medically Home Group as its CEO. Medically Home Group is the first commercially viable virtual hospital healthcare technology services company, providing all tools allowing its health system customers to safely bring hospital-level care where patients live. Rami began his journey in healthcare with McKinsey & Company, working together with health systems to improve patient flow across different areas of their hospitals. After over a decade with McKinsey, he joined Flextronics as president of their global services and software business. Welcome to you, Rami. Sarah Linares is the VP of Partnerships at Change Healthcare. She is an award-winning VP of Partnerships for Change Healthcare. Her team is responsible for driving innovation and value delivery in healthcare through productive, mutually beneficial partner relationships. Over the last 20 years, Sarah has become specialized in bringing new technologies to the healthcare market and building partner ecosystems. Sarah has been featured by Forbes and KPMG in Rewriting Healthcare and is recognized as a digital health influencer and advocate of virtual and at-home care models. Welcome to you, Sarah. And last but not least, we have Eddie Paloki. He leads the company in meeting the in-home care needs of healthcare companies and their patients nationwide. At WorkPath, Eddie has overseen the expansion of the company and its full-service platform to offer scheduling and dispatch of healthcare professionals through a nationwide network and seamless reporting and results delivered via an API. Under his leadership, the company has rapidly grown its business and today facilitates on-demand in-home services for Fortune 100 companies, clinical trial operators, and digital health innovators. Eddie guided WorkPath through its acquisition by Roe, a leading healthcare technology company. Prior to WorkPath, Eddie amassed more than 20 years of technology experience with startups and publicly traded companies in the healthcare and logistics industries. Welcome to you, Eddie. And before I turn it over to Anish, I wanted to mention that the chat is open for people to ask questions, but please use the username Anish for questions to send the questions directly to our moderator. So with that, I just wanted to turn it over to Anish. And again, welcome to the panel.
Great. Thank you, Arundhati. Thank you so much for those introductions. I think we'll jump right into it. And as she mentioned, please feel free to send questions. We are going to weave them in, and then towards the end, we'll have some time for Q&A as well. So the first topic I wanted to start with was around care modalities. And as we know, the definition of home health has evolved. It started with a very clinical, reimbursement-oriented definition based on what CMS would reimburse. But as we know it today, as we think about home health and home care, it is much broader than that. So I would love for our panelists to weigh in on that and start by talking about what is the next generation of health, of home health. Eddie, let's start with you, and then we'll go to Sarah and then Rami.
Yeah, absolutely. First of all, very excited to be here. Rami, Sarah, Anish, really happy to be able to have this conversation with you. So excited. Thank you for having me. When we think about home health, myself and at WorkPath, I really think of it as any care or health service that meets patients where they already are in their home. Defining in-home care is connected to one specific population or relying on a specific reimbursement, like you mentioned, Anish. I think it really places artificial limits on the type of care that many patients could and should benefit from. We saw this early on when we were talking in telehealth, which early on was really considered a tool for rural patients. But over the last few years, and especially during the pandemic, we saw that it's multifaceted and there were a lot more uses for it than we originally thought. For the same reasons that it has long been beneficial to the elderly, in-home care can really be an equally valuable option for many patients. Think about, a parent of 3 who needs to have an appointment to get routine blood work done. They need to make the decision of, should they go in, potentially take a half a day off work, forego wages? Do they take the children with them? Do they have to pay to have a caregiver? Or should somebody just come to their home? Obviously, we believe at WorkPath, they should have somebody just come to their home. So when we really think about kind of the future and the next generation of home health, I think it's a technology-enabled healthcare professional network who can quickly and safely, really efficiently, scale the house calls of the old into the 21st century. So more patients really have access to high quality care in their living room.
Great, thanks, Eddie. And it's really interesting how many years ago that used to be the model of care at home, right, where you would get in the care convenience in the convenience of your home. And I think over time, reimbursement models changed it, and I think now we are finding our way back. Anything to add to that, Sarah? You and Rami, you see it in your work as well. I'm sure you're seeing home health evolve quite significantly.
Yeah, and we'll talk more about the advent of digital health throughout our conversation. I was going to introduce the concept of value-based care that's not new, and those entities that are really stakeholders in one's health are looking not just at home health by definition, but also looking at home care and a number of other needs that have to be met, and how digital tools can bring that together. So I thought I'd introduce that, that concept. And it's, if you look at governments or ministries of health around the world, those models have been in place, and there's a lot we can learn in the US as we transition there.
Great. Rami, anything to add to that?
Well, first, delighted to be part of this illustrious panel, so thank you. The synthesis that I'd say of what Sarah and Eddie mentioned was really the home health of the future and the home health we need to decentralize facility-based care looks nothing like home health and home care does today. And I think that's the big thing we've all got to wrap our heads around, is it is very different. It is on demand, Eddie, to your point. It is 24/7. It is weekends and weekdays. And it's a set of services that, frankly, 10 years ago, people didn't think were possible to do in the home. PICC lines, x-rays, chemotherapy. We've all got to wrap our heads around the home health and the home care of the future looks nothing like it does today. And I think that's the messaging that you're getting from the panel.
Thanks for that, Rami. And as I think about it, I think there's a lot of promise in care at home, and I think the definition is expanding. To your point, it's overall care at home. It's 24/7. It's on demand, different modalities, etc. The piece that I'd want to touch on now is there's a lot of literature out there that would say that when you get care at the comfort of your home, there's lower infection rates, better quality of care, better outcomes, and it's a lot more cost effective. So the question I have for the panel is, and I'd love for you to start here, Rami, which is, what is different this time, right? I mean, some of these ideas and some of this thinking that let's move away from institutional settings has been around for a while, but we've not successfully seen the kind of adoption that we would love to. So what keeps you excited now, given that we're at an inflection point?
Look, there's a lot to be excited about. I think there are two forces coming together. Number one, consumers and the consumerism of healthcare started wanting care to come to them in much the same way as Amazon brought them all to us. Now consumers are demanding or expecting that healthcare come to them. And to your point, they're recognizing that comes with better outcomes for everybody. I think that's the first force. The second force is the acuity of the patients for whom we can care for at home, given all the technology, all the capabilities, all the services in the home, is dramatically different than it was 5 years ago. Mayo, as an example, 2 weeks ago, published the article of their first bone marrow transplant patient in their hospital at home. This is a patient who otherwise would have been 14 days in hospital, having that care, that treatment done in the comfort, the safety of their home. So between consumers demanding that care come to them instead of being forced to go into facilities that don't deliver the same outcomes, and clinicians having the confidence and the capabilities to deliver really high acuity care in the home, those two will forever change the way we view healthcare delivery.
Well, wonderful. And I'm going to, weave in a few questions that are coming in. So, as Sarah, you add to this. I think one of the questions that has come in is, in this new environment, is quality, how you measure quality, going to evolve? Would love for you to, add on to, what Rami opened with on what's different now, but then also touch on a little bit on how you're seeing quality being measured.
Yeah, I'll kick that one off with what I see data being used for in quality measures that we haven't seen in the analytics in the past. The advent of wearables, patient provided, social determinants, there's all these other data sets that we can now integrate with what we have in our EHRs. There's the claims data and sharing of data, the theme of interoperability, and that availability with some of the regulatory changes really allows for us to look at new dimensions of patient care and what outcomes we're delivering and improve upon quality. I was also going to add, relative to research, how much time I've spent, in the weeds with research. And I think one of the challenges with adoption has been the evidence and having the time spent on that evidence with some of these new digital tools at home. But I don't know about you, I'm seeing a ton of great papers and outcomes being reported around the world. So I think that that's contributing, along with the pandemic, to us being at this inflection point.
Anish, just one thing to build on that maybe Sarah can comment on. I think we have to recognize the quality of the data, the amount of data that we have when care gets decentralized into the home is night and day different. So a couple examples. In a hospital, when you push the nurse call button, number one is there's significant delays to nurse coming to your bed, and nobody can actually say how long that took, how many times you pushed that button, how that related to the other care you were getting. But in the home, we have exquisite data on how long it takes for a nurse to get there, how long it takes for a doctor to answer the phone when you call in. So I don't know, Sarah, is there more detail around the richness of the data that you get in the home and what providers in particular are doing with that?
Absolutely. I don't think I have the stats in my back pocket to mention, but I remember a study that Philips did using some data that was live stream and from the home and comparing it traditional methods. And it was pretty astonishing how much more accurate the predictions were, how much more confident we could be when taking actions.
Great, and that's great. And Rami, one thing that you mentioned as in your opening comments on this particular topic was around the level of acuity of care that can be provided at the home has evolved. I'd love for you to comment on that, because the traditional notion has been it is lower clinical acuity. But I think, you're doing some really interesting work with your organizations where that might change. So I'd love for you to comment on that.
Sure, and I think this is part and parcel of a whole ecosystem that is changing the definition of decentralizing the care. So one example, we're in a partnership with Mass General to care for oncology patients in the home, patients with pancreatic cancer that are in stage 3 and going through chemotherapy. The idea of caring for those patients at home so that we can keep them out of the hospital so they don't exacerbate by being in the hospital. It's just a whole new way of thinking about it. And the good news is, again, to Sarah's point about the data that we have, we're able to measure quantitative metrics of acuity for patients hospitalized in their home. And many of our customers are finding that the acuity level in the hospital in their home is a higher acuity than the brick and mortar hospital that they run. Because of how much better, the sicker you are, the more you need a hospital, the better it is for you to be hospitalized in the hospital in your home. Again, take the bone marrow transplant patient as an example. And that's one of the forces that are just driving all of this. And the ecosystem of the care required in the home is supporting that in ways that it wasn't 4, 5, 6 years ago.
Wonderful. Thanks, Rami. And, I think these comments, and Eddie, I'm going to come to you in a second, lead us to think about which are the populations where care at home is most applicable, right? And I know, Eddie, you and your organization have been at the center of that. So we'd love to, get your thoughts on, given the expanded view on what care at home is, the expanded technology, data, and analytics that is available, which are the populations that you see are going to most benefit from this sort of care? Eddie, let's start with you.
There we go. Yeah, great question. And to kind of, backtrack a little bit, what Rami and Sarah were talking about, there's exactly what we're seeing as well. This rise in consumerism is pushing a lot of this rise in the clinical trials is really pushing this desire to keep patients who shouldn't be in a clinic at home and really safer. And where we see, there's a lot of opportunities here. Obviously, we think there's a lot of different populations, but one where I think that can make a huge difference and scale rather quickly is clinical trials. When you think about enrolling diverse patients, participants, improving engagement, reducing dropouts, and really performing that care in the home, I think can be a huge benefit to clinical trials. And we've already seen, we saw decentralization of clinical trials really happening before the pandemic with as remote monitoring and things like that got better. But we saw, at WorkPath, we had customers coming to us saying, we have a clinical trial, but we cannot have this vulnerable cancer patient go into a clinic for the checkup. Can we have somebody come to them? And we said, sure, absolutely. And I think that population specifically, there's huge benefits, not only just to the patients, but when you think about the decentralization of trials, now a clinical trial that may be happening in San Francisco or Cleveland or Minneapolis doesn't have to worry about just pulling from participants in the area. It can really pull from anywhere in the United States. One of the customers we work there is Science 37. And they're really leading that shift in the decentralization of clinical trials. But I think that specifically, again, there are many others, but I think clinical trials specifically, there's a lot of potential and a lot of upside to having those patients being able to be served at home.
And Anish, I think we should almost reframe the question, which is what we're seeing is that the default increasingly when somebody needs facility-based care, whether that's a clinic or a hospital, is to get that care in the home. So the question we should be asking is what patients absolutely require being within a facility and why, and how do we best provide that to them? Because the default is now changing to the care that used to be in a facility, hospital, et cetera, going to the home. And I think to address one of the questions in the chat, there is no going back. I think at this fundamental level, this is a transformation that we cannot turn around. There won't be a place where we're going to go back to always going into the clinic, to no more telehealth visits, to not being hospitalized in your home. I think as a country, because of COVID, everybody has crossed that chasm. And it's because the providers are saying the outcomes are simply better, period.
Yeah, and Rami, to follow up on that as well, we heard, in 2018, kind of one of our beliefs in starting WorkPath was this belief, this assumption that people have a higher expectation for a customer experience from a local mom and pop pizza place than they do from healthcare. And what we saw in 2020 was not only just customers coming to us, but the patient mindset seemed to change. It was as more and more people were doing, obviously, telehealth, digital health. More and more people also said, well, can the next part, why do I have to get in a car? And if you think of a digital health company who the goal is, I'm going to sit on my couch, I'm going to text with my doctor, I'm going to have a video chat with my doctor. At some point, the doctor's going to say, okay, you need to have blood work done. And if that patient now has to get in the car and drive to a LabCorp request, any lab or a clinic, that completely broke that whole model. And I was talking to a local health system here in Richmond, and what they started doing was they were doing some pilots doing mobile phlebotomy. And they overwhelmingly heard from the patients, wait, if you can come to my house now, when the pandemic's over, can you come to my house again so I don't have to drive downtown? So I think obviously there's a business side of it, there's the outcome side of it, but I think just patient mindset has completely changed.
Absolutely. And Anisha, I just have one thing I wanted to add, which is a completely different dimension of areas that can benefit from these new models. There are a lot of health deserts, some of them being maternal, maternity and infant care deserts. There are a number of opportunities just for the competitiveness that's happening in ambulatory and primary, care and clinic care today. Look at I just was reading about was a Dollar General and their whole plan. Look at where Walmart's at, Amazon's news, right? So think about how much transformation our provider clients need on this topic and being able to meet the consumerism demand of what kinds of things people initiate from their home when it comes to their healthcare.
Absolutely. And Sarah, one of the things I was going to request you to touch on also was, I think everything that all three of you have talked about points to the interplay of different stakeholders. In your role in establishing different partnerships between different organizations, how do you see that different from many years ago? Because for this to really come together, you'd have to have the hospitals, the physician groups, the labs, technology players come together to deliver this holistic, sort of ecosystem as Rami described it.
Yeah, I think that's, where Change Healthcare has a strength and where I'm, very well positioned to bring this all together, because we're sitting at the intersection of all of these entities. We're able to be a bridge for things like interoperability and data exchange. We're able to provide data science environments with the rich data that we can provide and provide APIs and different tools to help digital health be really fostered. So that's really the lens that I'm sitting at. So we're seeing everything from retail giants and banking giants jumping into playing a role, employers increasing their role, all of those things in addition to the transformation happening with payers and our traditional health systems and providers.
Great. Well, I'm going to jump to some of the questions that have been coming up on the chat window. I think they're quite timely as we are, talking about these modalities. So I think the first one I'd love to touch upon, and which either one of you can kind of jump in there. I think is the question of wages, right? We have seen, the minimum wage is what it is. A lot of home care providers, are at minimum wage or part-time, and we are going to see wage inflation, happening across the country. To what extent is that going to, impact care at home? Would love for you to comment on that.
And maybe I'll try to frame it. So to me, what we have to go back to is when we're decentralizing care that used to take place in a facility, take hospitals as an example, what you're really doing is arbitraging the fixed costs so that you can turn those fixed costs into more care for a longer period of time. The average hospital room has about $2,500 of fixed cost per day to support it. When you provide hospital care in the home, you can put all of that towards more clinical care for more days. So in that context, can we afford to pay people $25 an hour from home health, 50, 75? Absolutely, because it starts from saying we're arbitraging patients that otherwise would have been cared for in facilities. And that's where we also have to make sure that we watch induced utilization and making sure that the dollars are being spent on the highest acuity patients that would otherwise consume most of our facilities. So I think that's the general framing, and then you can apply that against every aspect of care that's delivered in the home.
Eddie, I'm sure you come across this in a lot on your platform as you connect, people to where care is needed. Any challenges you're seeing here?
No, we are. I mean, obviously, we on our platform we have nurses, we have phlebotomists, and so what we can do there is obviously pay them well. Exactly what Rami said. When you think of and if we're just talking about phlebotomy, if you think about a lab, a company who has a lot of brick and mortar locations, there's really no need to have that overhead anymore. So we can take that overhead and we can transfer that into potentially how we are paying the people. And what we've also seen on the platform as well is there are some people who may be a nurse who has a couple of shifts a week, who now wants to pick up some extra work on the weekend, going to people's homes, really working in the neighborhood where they live. And so it has not necessarily been an issue for us. We think that obviously our network is the backbone of the service we provide. So the wages have not necessarily been an issue.
Yeah. And I think on my side, I'm seeing platforms that can allow for various types of care providers, and that would flex all the way up into clinical roles as well. And, I don't know if Honor is an example, but I was just thinking of those kind of this Uber like model when you need to call upon services and how you orchestrate that. And I think that creates an opportunity for people to make more money in providing these kinds of at-home care and have a career ladder to work up.
Including, by the way, Sarah, you brought up sort of underserved communities. That should also include the families that are providing care either episodically or longitudinally for patients. If we liberate costs that are otherwise being spent on buildings and apply those to care in the home and compensate the families for the care they're providing, especially underserved populations, that's a workforce that we're not fully tapping into today, which we can use this change to actually tap into and improve outcomes and improve the care that's delivered.
Wonderful. I think what I'm hearing from all three of you is, I think if we take a step back and look at total cost of care, not just the wage or not just one element or the other, I think what we will find is not only is care at home more efficient overall when you take the big picture, but it also allows us to deliver better outcomes, better experience, and touch on a workforce that we haven't been able to explore. One other question from the chat, and then we'll move to digital health in a second, which is, I think there are a series of questions around regulations. We have been in a period where there have been emergency use regulations, whether it came to telehealth, home health, home care, etc. And without going into any of the specifics, because I know the regulatory and legislative environment is going to keep evolving, I think the question I would have for the panel is, do you see regulations and the legislative agenda in general supportive of this transition or this exploration of care at home? Rami, do you want to start?
Sure. So I mean, the thing I would say is I really take my hat off to the folks at CMS who, for example, passed temporary legislation around hospital without walls and hospital at home. Every signal that we're getting, and over 150 hospitals that are caring for patients in that model, is that this is here to stay. And fundamentally, if we can prove, which we have, a model that delivers better outcomes at a lower cost, which patients and providers prefer, I think we're getting a lot of momentum among the legislation to continue that. The mechanics of how they do that are very complicated, and I think we'll have to sort of take steps in that direction as it's made permanent. But everybody we talk to is very focused on how do we make these changes permanent going forward. Nobody that we talk to wants to go back to the way things were.
Yeah. And on our end, what I'm seeing is, as these regulations, particularly around digital health and telehealth and where you can practice medicine and what's reimbursable by the payer, as that's been dynamic, we at Change Healthcare have to keep up on that, in real time to support the clients using, our networks to understand what is reimbursable, what's out of pocket. And if you think about price transparency, exposing that out of pocket as early as possible, giving options to the consumer, helping them make smarter choices, which I hope to see in digital health become choices of at home, or in-person care when possible.
Absolutely. I think, even our research and the work we've been doing, I think if you look back over the last 10 years, I think there has been more and more of a shift towards home settings or non-institutional settings. We've seen this, from a LTSS perspective, in Medicaid and some other areas as well. So I agree. I think we're going to continue to see that. I think shifting gears a little bit towards digital health, and I know, Sarah, you alluded to this a little bit earlier, so I'm going to start with you, which is, many will say that the global pandemic, obviously it had a lot of challenges, but one of the things it did was it really accelerated adoption of digital health. From your vantage point, what changed in these last 12 to 18 months? And then Eddie and Rami, I'm going to come to you also through a little bit more nuanced questions, but would love Sarah to start here.
Well, the demand for safely delivering care that wasn't necessary in person was there, and regulatory changes rose to the occasion to help pave a way for us to accelerate that around the entire nation. And in many ways, modalities like mental health have been another consequence of the pandemic, but it's been an opportunity for mental health providers and platforms that are able to organize around delivering that in a more modern way. And in my viewpoint, we're seeing hundreds of startups and developers, within the health ecosystem coming to change healthcare for APIs in order to power the eligibility all the way through to the claims or the cost transparency pieces I described. That's been by the hundreds, surprisingly, and definitely a big multiplier from any prior year when you think of some core, claiming and eligibility functionality that's been in place for years.
Wonderful. Yeah, that's exactly right. And another example here has been, I think, technology has become accessible to several players. So Eddie, I'd love to get your thoughts. Your organization has been, sort of at the forefront of providing cloud-based, web and mobile applications and enabling a workforce. How have you seen the last 12 to 18 months create opportunities or challenges in what you're doing?
For us, what we've seen is obviously digital health technologies, digital health companies are really trying to bring a greater patient experience. And as they continue to ramp up, as more patients use digital health, use telehealth, not everything can be done virtually. So there continues to be a need to have an in-person, whether it is, and there's a stat, I think it's 70% of all medical decisions start with lab results. And so when you think about that, when you think of the digital health companies, at some point, they want to get out of that 30%. They want to grow beyond the 30% of things they can do virtually. And they want to have somebody come to the home. They're going to need to collect blood work. And as we sort of mentioned earlier, if you have a great digital health experience, and then you have to go into a clinic, you've kind of broken down the whole experience. So I see us, and very similar to what Sarah said earlier as well, all of these APIs, I see WorkPath, and really I see in-home care as a perfect complement to digital health. I see it something that is intertwined with these digital health experiences. So from a patient journey, from a patient perspective, I can text with a doctor. I can see, a telehealth, I can do a telehealth visit. And then if I need somebody to come to my home, maybe it's a vaccine, maybe it's a routine checkup, the person just shows up the next day or that day, possibly. And it's one seamless experience. And again, as more and more people use these experiences, there's going to be more and more opportunities for consumers to say, okay, now can somebody come out? Because these in-person visits are going to only accelerate through digital health. And the answer to that, I think, is in the home.
Yeah, I think you touch upon a very interesting point, which is around the interplay of digital and in-person. And I think, as we go to Rami, who you're leading a business that not only does the interplay of, your digital platforms, in-person care, but also remote monitoring, medical devices. So the question I would have for you is, as you are leading this sort of revolution to deliver more higher acuity care at home, how do you ensure this is on demand, connecting so many different pieces, and there is lower variability?
Such a great question. I think just to emphasize one thing that Eddie had said is we don't believe that we're going to get anywhere disconnecting the digital from the in-person. All of the interactions that are meaningful require a combination of the two. And importantly, they need to be done on behalf of the provider. So our view is that all the digital health companies need to enable the provider to give great care to the patients and sort of augment that patient-provider relationship and not disintermediate it. Now, Anish, to your point, what that means is the provider should expect and demand reliability, consistency, and standardization of what happens in the home, which goes back to sort of where I started, is we need to fundamentally retool all those resources going into the home. One example of that we'll point to is paramedics. We think paramedics are one of the great under-deployed capacities in American healthcare for providing high acuity care in the home. Eddie's given some wonderful examples of sort of lab draws of phlebotomy. Take paramedics, what's amazing about them is they go into the home, they've got iStats with them. They can do diagnostics in the home to get the results back within minutes to the provider, who can then change the infusion based on the results from those in-home point of care diagnostics. That rethinking is part of what's going to make it easier for us to develop the care and deploy it consistently and on a standardized basis. But we're going to need to think very differently about what we've done in the past. And I, some of the comments in the chat back to regulations, states, for example, are changing and are going to need to change their stance towards paramedics to enable this.
Wonderful. One of the things, Rami, while we are on it, is some other parts of the world, right? I know there are examples that come up just, on hospital at home. And, one would argue, if you look at Australia or other places, they have much higher, admissions that are done at home. That's just one example. Obviously, care at home is much bigger. What is the impediment here to get to that point? We are nowhere near even 1% of our admissions in the home or at that level of acuity. What is going to change from a technology perspective or from a regulation perspective that gets us there?
We believe, just to baseline the group, we believe that 20 to 30% of the admissions that are done into a brick and mortar hospital today would be better off being done into virtual hospitals in patients' homes and decentralizing the care, including, by the way, respite sites. We have examples of some health systems that are in the double digits on that journey. The two big ones that we need here, one of which I think we made great strides on, is just a regulatory regime and the changes we've been talking about. So, Anish, to your point, as we sit here today, France has 15,000 patients on census in hospital programs in the home. Now, those are lower acuity patients, but the reimbursement for those has been available, for many, many years. And the second one is exactly the conversation that we've all been having here, which is the ecosystem of providers going into the home need to be retooled in order to do that. There was a question in the chat, the traditional home health companies, LHC and Medicis, are they embracing this? And I would say, without naming names, is they're absolutely embracing this because, like the panel, they are seeing this as the future. They want to meet patients where they are. They want to continue to drive more care into the home because it generates better outcomes. And everybody in the ecosystem, from the providers in the hospital to the home health companies to everybody that sort of is part of delivering this care in the home, needs to increase availability, capacity, ability to respond. And that has to the earlier question, has to come with paying more into that care because it's a higher level of care, which ultimately is going to reduce the total cost that we face either as a system, as a payer entity, or as a country.
Let's be honest, there's some risk to some of this at home when you look in the communities, when you think about the ROI of brick and mortar, the amount of volume and procedures and things that you need to flow through for you to have such a facility. And so I think we're balancing this knowledge we need to go back to the home with hospital administrators who are asking themselves, how do I keep my operation open and available for those who do need that in-person care, especially when we look at the rural areas.
Right. This gets us to this notion, I think, which some of you had brought up earlier around ecosystems of care. And I'd love to talk a little bit about that because I think we touched on it in the earlier part of the discussion. I think we've established, how care at home has evolved. What is now care at home? What is the need for it? Why the time is different, right? Regulations, technology, the data and analytics that wasn't previously available. So the question I would have for the panel, and Sarah, I would love to start with you, is, health systems are partnering with different players in the ecosystem, and we are seeing different ecosystems evolve. How do you see these ecosystems play out? Will they be by population segments? Would you take a particular segment, for example, the young and healthy, and you would follow them from what they need at home all the way to an acute care episode? How do you see these ecosystems get created, and what will be the key success factor here?
One of the things I love about digital health and its integration into health systems and into employers and into the fabric of anyone touching healthcare is there's typically product managers with strong design thinking doing patient journey work or journey work in general. And I'm seeing that the industry is greatly benefiting. These ecosystems are benefiting from someone charting out these experiences from the lens of a patient or a person or a consumer, right? And starting to get people to talk together about where those choke points are, where things don't make sense, why in a telehealth visit would my doctor send me to a lab who would only take a piece of paper or a fax, and why can't I have that digitally, right? So how do you start fixing the systems and the back end and the players involved to optimize for the patient and their experience? That's what I'm seeing a trend in is more interest across the ecosystem to be looking at things through the lens of the patient.
If I could, I'd love to give what we view as the number one result that people will find when they do that patient journey. Sarah, I think that's so well said. Access 24/7. That is the biggest shift that we have to make, whether it's your primary care doc, whether it's the hospital going into the home, whether it's the phlebotomist, Eddie, that you spoke about. The key success factor within the ecosystem for us to really help care at home take off is going to be 24/7 access. We've got to retool around that fundamental idea, which doesn't exist today. Today, your typical home health ecosystem, as long as you need it Monday through Friday, 9 to 5, schedule the day in advance, you can get it. And we've got to retool on 24/7 on demand within an hour. That's, in my view, is the key success factor.
Yeah. And Eddie, were you good? I was going to point to you as well, because, you've been, at the intersection of, obviously technology and platforms are a critical glue to bringing these different players together, and would love your thoughts on what would make this ecosystem successful.
Oh, absolutely. And to touch on something that both Sarah and Rami said as well, when we talk about the patient first, it's been interesting for us because we take the approach of, even though the way our business works, we work with digital health companies and we're their provider, but we still put that patient first. We've had to kind of, even going through the partners we work with, really retool and rechange their thinking to be more like ours of, if the patient needs a phlebotomist or nurse to come out tomorrow at 9, that's when they need to come out. Let's not try to have the patient fit into kind of the labor's schedule like it's typically done, or let's not try to change things for them. Let's do what works for the patient. And so really it's the consumer mindset. It's really, let's treat them, let's make sure they have a great experience. And we used to joke at WorkPath. I mean, one of the things we do is mobile phlebotomy. We have a phlebotomy network, and we used to talk about, typically people don't like a stranger coming to their home. Rarely people like to get stuck by a needle. So we have to take the experience of a stranger coming to your house and stick you with a needle, a good experience. How is that? And what's cool about what we're doing is there are models for this elsewhere. I mean, you can get an Uber coming to your house, Grubhub, all of those things have good, for the most part, consumer experiences. Just that experience hasn't been necessarily in healthcare yet. So we can model some of what they're doing to give the patient a really great experience. And kind of to your question, Anish, I kind of go back into something Sarah said earlier about the amount of companies who are using APIs and things like that. I think there will be, similar to WorkPath, I think there will be more and more companies who really want to be that infrastructure and will play in a specific vertical. And that's how the ecosystem will continue to grow. And again, self-plugging WorkPath is we are a labor network. So if clinical trials needs to send a nurse, they can use us. If a digital health company needs to send a phlebotomist, they can use us. So I think we will continue to see this ramp up in healthcare of these tech companies who want to be those infrastructure pieces. And I think that's what continues to help build, because I don't want if a digital health company, if any company, wants to start doing care in the home, I don't want them to have to set up their own network of people and worry about the tech. How does the tech work to dispatch and all of that? We want them to use us. And I want them to be able to take part in all these other services that are growing and out there.
Wonderful. Eddie, based on what you were saying, one of the things that comes to mind is, as these ecosystems get created, I think a couple of questions come up. One is, how will the health systems respond, right? I mean, they are generally have been wired to cater to a certain amount of volume. If the volume goes away, the economic incentives don't necessarily always align. Also, the payers might be worried that is this going to just increase utilization at the end of the day? Maybe most cost effective, needed, but is it going to increase? What have you seen on that? From a perspective of as these ecosystems have grown and some outcomes that you might have seen.
Yeah, from our standpoint, what we have seen is obviously going into the home really has a lot of benefits, removing barriers to care. So we can now reach to, and I think Sarah mentioned this earlier, our network path covers 95% of the US. So we can now get to people who may not be near a clinic, may not be near a health system. So we have access, better access. If you think about somebody, and talk about blood draws again, needs a blood draw, there's a high percentage of people when you go to your doctor and they say, Rami, you need to have your blood drawn, here's your requisition form. You're probably going to go put it in the glove compartment of your car and say, I don't have time to do that, I'll do it in a week or two. You never get that care, your doctor never gets that. So I think it will ultimately make people healthier and have better outcomes. I think there's some really interesting stories as well, just about how this helps to give providers greater insights into patients' lives at home. I think that helps the social determinants. It helps with greater engagement. And Rami was mentioning, just a paramedic going into somebody's homes. There's so many more things they can do once they're there. So it opens up, again, it's a lot more of an opportunity. And I think all of this ultimately leads to a better patient experience. And, my quick story, my wife's great uncle is 97 years old, lives in the farmhouse in Maine that he was born in. A couple of years ago, he had heart surgery. After his heart surgery, the doctors kind of gave him all the do's and don'ts, do this, do that. He went home. Luckily, a nurse ended up coming to visit him. And once they walked in, realized he sleeps upstairs. His stairs are narrow because it's an old farmhouse. There's no handrail. He just cooks on a wood burning stove. He doesn't have heat. And all of these things they learned within 30 seconds of opening the door, they were able to completely change his care plan, because the stuff they told him to do, he was never going to do. He couldn't do it. So just going into the home. Now, with the new care plan, he's probably not going to go back to the hospital. He didn't go back to the hospital. They were able to tailor that for them. And again, ultimately, it's a bet that these things are going to work. Ultimately, create a better both experience, better for insurance companies, better for health systems.
Wonderful.
Nisha, I think.
Go ahead.
No, sorry to interrupt. I think we have to question the fundamental premise of the way you frame the question, which is we don't view the health systems as losing this volume. We view this as enabling the health systems to provide this care in a unit, a ward that is not encumbered by all of the additional costs, the fixed costs of that they have there. So the health systems are actually going to deliver more care in this model on behalf of the patients coming from the health systems. The difference is they're going to figure out how to do it in the patient's home, because ultimately the patients don't want care from a payer. Patients want care from their doctor. And as the acuity of that care increases, the more they're going to want it from their physician and from the health system. So we don't view it as losing patients from the health system. We view the health system as providing more care over a longer period of time to the patients that it's in their mission to care for in an expanded community, because now they're not stuck with just the patients who can drive to their facility.
Right. And I think one of the other things we are also seeing is, health systems are seeing readmissions that can be avoided. They're seeing people coming back when they could actually get that care. So I think, gradually the incentives are also aligning. But let me ask one question, which, from the example that Eddie, you provided, and maybe I'll start with Sarah here, just to give you a heads up. But because you can get to the home, you can identify non-clinical needs. You might need transportation. You might have food insecurity. You might have the need for personal care aids, etc. Is this finally going to be a trigger towards health equity? What are your thoughts on that? Let's start with Sarah.
Absolutely. I was thinking about where we're going with, insights being delivered, just generally speaking, as an industry in different points, and the social determinants and the personalization of care that's possible if we just use the data to really know someone. And when we are engaging with them, whether that's setting an appointment or answering questions, it's really with that context. And that's what I'm seeing a lot of builders working on, whether they're in a startup, they're in the health system and with resources to do that, or even in a payer, and how we all bring that knowledge together to create that picture is kind of the work that I'm doing in the partner space, right? Because each of us share a piece of that knowledge, and how we can exchange that to see the full picture is kind of a mission that we're after when you think of all of this data coming together.
And Anisha, I love that we're talking about health equity. I love we're spending more time on it. The fundamental push behind your question is, as we decentralize care into the home like this, your ability to drive to a hospital in Boston, Chicago, New York, LA shouldn't influence the quality of your care. And the reality it does today, and everything we're talking about, everything Sarah underlined, is if you live in rural Oklahoma, you should be able to get the same level of care as living in any one of those cities. And this idea, as we figured out how to decentralize care, that's the big thing that it's going to drive for everybody who lives in rural parts of our country, but also countries that are predominantly rural outside of the US.
Yeah. And Eddie, I mean, you started this discussion by sharing a very powerful kind of personal experience. So would love your thoughts here as well from a health equity perspective and social determinants.
Yeah, absolutely. And I can give another example. We did a vaccine drive, COVID-19 vaccine drive with Roe. And it was with Roe, and it was the New York Department of Health. And the goal was to really vaccinate some of the most vulnerable in New York City. We had 70% of the people vaccinated reporting having one or more COVID-related comorbidities. 2/3 were minorities. 40%, so almost half, 40.4%, said they were homebound and couldn't get to a vaccination site. 27% of those said that they were scared to go to a vaccination site. So these are people that wanted to get vaccinated, couldn't for whatever reason, and we were able to go into their home and vaccinate them. And it was simply bringing somebody to them. Now, I mean, we can do the math to say now that they're not vaccinated, the families who live with them, and now that they are vaccinated, the families who live with them are safer, and there's kind of a cascading effect. But we were able to take those people and help them get vaccinated by just coming to their home. I mean, it was a simple notion of come to their house instead of asking them, again, to get on the subway, get in a taxi, get in an Uber, drive to a vaccination site when they couldn't anyways.
Yeah, that's yet another very, very powerful experience. And I think this is what we are seeing as care is moving to the home. It is meeting unmet demand. These people would not have gotten the care because they were, to your point, homebound and so forth. I know we are getting close to our time, so I'm going to focus a little bit on the challenges as well. But let's just, if you take a step back, we talked about how the definition of care at home has expanded significantly. We talked about digital health significantly accelerating the formation of these ecosystems and an increase in push towards care at home models. Lots of benefits. We talked about aligned incentives and so forth. So the two things I'd want each one of you, and we can go around and touch on, is let's start with the first one. What are the unintended consequences? So let's say if we just kind of flip the table and say, let's take a skeptical view, like what are the things you would want to guard against as you're leading your businesses to drive a massive change where care is going to be delivered in the home, there's going to be health equity, etc. What are some unintended consequences that keep you worried and up at night? Since you're on the spotlight, Eddie, we'll start with you, maybe then go to Rami and then Sarah.
Yeah, sure. Yeah, it's a great question. It's something we think about all the time. One of the things that we absolutely make sure that we want to protect, because with any new innovation or the adoption of a new model in healthcare like this, it's critically important that the expansion be done in a clinically sound, equitable, and affordable manner. So we need to make sure that the phlebotomist nurse who's going into the home, everything is sound clinically. So we need to make sure, because they are not in a doctor's office. So we need to be very protective of that. Obviously the healthcare system has enough challenges. So as more conditions, whether it's clinical trials or other things that we add, other services, as we continue to expand, we also need to make sure that we're really tracking the quality of the care. That we really want to make sure that's not lost. We absolutely have a lot more data, as Rami said. I mean, we know how long it takes a phlebotomist, a nurse to get to somebody's home, how long they're there. We also want to make sure that we don't lose the second half of that. How is the patient doing after the fact? Making sure that we can track the outcomes, making sure that we can track the success rate.
Rami?
I love that. What I would just add is from the patient standpoint, as we look to move away from institutional sites of care and decentralize, we can't be overly focused on the home. To the point around health equity and access, we also have to figure out how to do this in sites other than the home that don't look like big buildings, respite sites, churches, other ways that we can provide this to people who don't own a home, who don't live in a home. I think that's thing one. Thing two, similar vein, Sarah, you brought this up, critical access hospitals. We have to, in parallel, retool critical access hospitals because as more care goes into the home, the average census for critical access hospitals is somewhere between 2 and 6 patients anyway. That wasn't financially sustainable to begin with, let alone after this change, it's delivering better outcomes to the patients. So how do we retool critical access hospitals as part of this? Maybe we need more standalone EDs, smaller hospitals with an ED, couple ICU beds, and OR. Our whole notion of what a critical access hospital has to change. And if we don't, the unintended consequences, and to your point, are we're going to further weaken a system already so very weak to begin with.
I'll take the technology angle with it, and thinking about my depth in ML and AI in the last 5 years, especially the ability to take out the bias, to be careful as we're building the underlying insights and recommendations. So critical. And as we're moving very fast, it's easy to bypass some of those things that you'll be considering if you're in a data science, data engineering team. And if you're in one, having an expert who's a clinician or someone who's an expert in the field you're building the insights for, I found to be a really important part of the development. And then just the apps and the technologies that are available. How do we as an industry get to a point, I know we're starting to for Mayo and others, where there's a sense of trust that we can establish as a consumer of what is safe to use, what's good to use, what's not. What are those mechanisms? We're familiar with FDA. How do we build consumer confidence in some of these applications and at-home services so that there's trust?
Yeah, absolutely. I know, Arundhati, there are a couple of other questions and we have 2 minutes left. Could we take one more, or are we going to run out?
Absolutely. Go for it.
Great. So I think, and then I'll allow the panelists to wrap their comments as well. I think generally we sense a lot of excitement from a technology, regulatory perspective, consumer journey, outcomes. So many good things that we've heard from the panelists. I think the question has come up, which is, what happens to the institutional assets? And I'll broaden it beyond just hospitals. But as care moves more to the home, how do we have these institutional assets that are quite ingrained in our system? Is there a glide path? Is there a more disruptive path? What do you see out there? And maybe Rami, we can start with you.
Sure. I mean, what we see is some very exciting projects to reuse the assets that already are underutilized and are going to become further underutilized as this care gets decentralized. So moving away from thinking about a hospital to, for example, thinking about a health campus, thinking about additional housing, thinking about additional assisted living facilities for the elders as we have the aging of the population move through. We know how to use these buildings. We just, on behalf of the patients, shouldn't be using them to force patients to come to them to get great care.
Eddie and Sarah, anything to add to that?
No, I agree with what Rami said.
Yeah, no, I'm just seeing a huge uptick on executives of health systems, really putting their dollars into the future of healthcare and what that means for their facilities, their partnerships. There's even the idea of, do you outsource your at-home services like they've been in some cases for telehealth, or do you build it yourself? What platforms, all these decisions, right, are being made. And I just see it as an important time for the industry to make good choices to prepare us all for the future.
Great. Wonderful. Well, I know we are almost at time. I'd really like to take this opportunity to thank Eddie, Rami, and Sarah for wonderful comments. I think you all are at the forefront of what we believe is the right path we are all passionate about, and hopefully the attendees got something really insightful as I did. I'd also like to thank the MedCity team, and back to you, Arundhati.
Thank you so much, Anish. I will take the opportunity to be a little self-indulgent and ask a question of you, Anish, and then to the rest of the panel as well. For a person like me, I got 2 kids. I have parents that live with me. I have a husband who I also occasionally take care of. So for a person like me, the move to the home and the televisits and all that is fabulous. But to take a slightly contrarian aspect, what if I'm 85 years old and my partner is no longer alive, my kids live away from me, my grandchildren are also away in college, and my only source of social interaction could be going to the doctor, dressing up and going to the doctor. When we move to home health, do these people become further isolated?
Yeah, let me start and then I'll turn to the panelists as well. Social isolation is a huge thing. In fact, I used to be on the board of a nonprofit that would serve hot prepared meals or groceries. And oftentimes we would hear from these vulnerable people that the only person they were meeting in a day was the person who actually delivered their meal or groceries. And so social isolation is absolutely critical. But I think what we have seen is, and I'll give you an example, but what we've seen, at least in my experience, is that as care is provided at the home, there is some social interaction between the care provider, whether it is clinical or non-clinical. It is more personal. It is also in a setting that is more comfortable for the consumer versus a clinic where you're not relaxed, you're sitting in a waiting room, etc. So from a patient perspective, or a member or a consumer who is getting care, the interaction is not only more frequent, it is also more personalized and in a setting that they are more familiar with. And I think that's what keeps us excited about it. I'll give one example. There's a leader that I have been talking to who leads the care at home program in Singapore, and his own parent was in a hospital for a long period of time. I think about 90 days. Every other week was getting infections, was not happy, etc. Finally transitioned into the home, provided the right support model. They had both clinical care as well as non-clinical care, dealt with the social element of it. And over a year, the person did not have a single infection. So the person's happier, the person's healthier, and it is lower cost. It can be done, but you need the right set of people to come together to make it happen. So that's what I've experienced, but I'd love to hear, what the panel has to say.
Yeah, and Anish, I'll jump in real quick. What you said is exactly right. One of the things we talk about at WorkPath is we're a tech company, yes, but we're really a tech company to enable a face-to-face in-person meeting. So what we want to do is, as soon as the nurse gets to the person's home, let's get out of the way. Let's them have a face-to-face. Let them be social. And what we have found when we kind of talk to patients, when we talk to our providers, is that in-home is so much more personal. You see pictures of their kids, you can talk to their dog. So there's things like that I think that from a social perspective it could be much better than somebody going into a doctor's office. So yeah, the in-home piece, obviously there's absolutely a social component to it, and there's a face-to-face component to it.
And I'll just add quickly that I think for us, it's about knowing people's preferences. Back to that know me, whatever way that is, whether it's through data or you volunteering, every person's going to have a preference. Some things you're going to want in the home, some things you're going to want in person, and there may be that person who wants everything in person. So I think it's about making all these omni-channel methods available for people of all ages to get to the care they need.
Look, I want to add, I think you guys all said it beautifully. I'll just take this opportunity to say thank you to so many people, including this panel, that are working so hard to get care into homes so that patients don't have to go to institutional sites. So thank you.
Yeah.
And a big thank you to all of you. I thought this was a very engaging discussion.